Let's start with Mrs. Ilori. Simply because the Nigeria Center for Disease Control is protecting the health of Nigerians. And recently, you've been talking about risk communication, behavior change in communities. Very briefly, what have you done so far about that, and what has your experience been like?
Our mandate is to protect the health of Nigerians. And one of the things that we have done so far, we have a very good risk communication team. And most of the activities we do is targeted messages. Because, we notice that giving just general messages to people, telling them, do not do this, does not help. We've done a lot of that. So what we do at the Nigeria Center for Disease Control is to analyze. We did some assessment of the communities. We went out, asked questions, tried to understand why they do what they do, and then use that to have targeted messages to them. So I'll give you an example with the Lassa fever outbreak that we have. Now we went out to the 3 hotspots. We have 3 hotspots where we have Lassa fever outbreak. That's Edo State, Ebonyi, and Ondo State. So we wondered, why are we having so many cases, confirmed cases from these places? So we actually did an assessment, and we tried to understand the culture. So having targeted messages to the community is very important. Then the other area where what we do in NCDC is also trying to target, we talk about communities. And most times when we say communities, we are talking about the rural areas. What about the urban? How do we get to them? So we have the social media, Twitter, Facebook, all the other social media, whatever that we use. Yeah. So we are also doing that. So we are on Twitter. We're targeting the youths because the youths are very important. In fact, I think the youths carry messages.
So the key thing here was to ensure accountability, and engage communities in whatsoever we are doing. Okay. So at the grassroots level, we revitalized the World Development Committees, which is being chaired by a traditional leader. And we created another office. Everything before was polio. Now we have LIO at the local government level. We now created, LIO was just featuring on polio campaigns because there is money. So we now said, no, let's appoint somebody as RIO, Routine Immunization Officer, fully in charge of RI. And the work of this RI is to interface with the World Development Committee, the traditional rulers, the CBOs, the NGOs at the local government level. They meet regularly. And he makes sure he checks the data from these facilities before submitting to the LGA, state, and national level. What we really discovered was that we now increase the number of sessions of RI. All urban facilities, tertiary, secondary, and urban PACs must conduct daily RI session, and vaccines must be accounted for. So supportive supervision was strengthened. All eyes were on everybody. Community leaders were regularly engaged. Households were regularly engaged. And we created CHIPS program that mobilized these mothers and children from their homes to facilities to receive immunization. So they interface with the communities, with the household. It doesn't end at all the communities. Household mobilization is also very important. Thank you very much.
It didn't make sense to me that some parents would not take their children for immunization, because one thing is clear: parents love their children. So we said, okay, let's start something. I discussed with Dr. Chizoba. Then I said, let's adopt a community that is really, they don't do immunization, they don't do anything immunization. Let's see what the reason is. And then we take it from there. And let's make it simple. Because once it becomes difficult, it's not sustainable. And then we adopted a community called Damangaza and Usawa. And when I spoke to the mothers, they love their children. They want the best for their children. They want healthy children. However, they were not taking their children for immunization. Why? They didn't believe in it. As simple as that. They did not believe in immunization. And then when people come to talk to them about immunization, they don't believe them. And then that became very key. So why don't you believe that immunization works? What's the problem? Because immunization is a very peculiar thing. It is the only thing that you take a drug and you're not ill. You take medicine when you're not sick. So, and then when you now take the medicine, you may become sick. So you see where the problem is there.
Yeah.
And then when they go for immunization, when they do ROI, even IPDs, there's the information to tell the parents that, your child may have a fever or all those kind of things. And then I didn't take my child for immunization, my child is not sick. You take your child for immunization, your child is sick. Mm-hmm. Next time I won't go. As simple as that. So these are the simple things. Sometimes the things that make the difference is not what you think. It's just those simple things. And then we started sensitizing, talking to the people in the community. Very, very importantly, the people must believe you. It's not when it's politics, 2 months to politics, you start coming to communities and all that. And then after politics, so if the people trust what you say, then they believe what you say, then you can get a whole community to immunize their children. And I can say categorically, that community that was not immunizing, today they have over 90% coverage in that particular community. Simple. Believe in vaccination. Believe in the people that deliver the message. Communicate with the health center. Health center communicates with the village. And that's it. So now with this in mind, we said, okay, this strategy is working. It took us 5 years. 5 years of back, forth. Yeah. We tried every strategy. The beautiful thing about coming from the private sector, I came from the private sector, innovation is anything that works. So today we go with the fathers, we talk to the fathers. Tomorrow we talk to the traditional rulers. Next tomorrow we talk to the mothers. Then we collaborate with the FCT. Then we collaborate with the primary health care center. Then we talk to the fathers again. Then we talk to the mothers again. Then we beg the fathers. Then we beg the mothers. Then we pay school fees for some children. Then whatever it takes to make sure that that message gets to where it's supposed to go.
All right, thank you so much, Chika. Thank you so much, Chika. Let me use, Christian parlance. I think it's an abomination for Nigeria to be dependent on donor support for immunization. How do we get government? And government at this instance is federal, states, and local government areas to fund immunization. How do we stop, depending on donors for this?
It's unbelievable. I think that's why I said we have to have national pride. Yeah. We have to be proud of ourselves. We have to know that, and this morning I was telling people that outside, that when I go outside and people tell me I'm BA Harvard, BA Imperial College, I say, me I'm BA Ibuagala, BA Sambisa, BA whatever. Because I never left this country. All my education was here. And no matter what school you went to in this country, standards were the same. Yes. We had a country that had pride in itself. We lost that pride. We don't know what it is. We need to get that back. Until we get that back, and that's the way we need to look at it. It's not the government alone. Even what the individuals are doing to disgrace Nigeria. Maybe we're taking act from our leaders. The legislature does not agree with the executive. Last year, the Ministry of Health put 5 billion or so for polio to match the Gavi whatever. The legislators came in and took 3.5 billion for what they call the constituency project. Which there's no project, but there's constituency. And these are some of the problems we're having. So I think until we go back to those basic things about integrity, which many of us, goes back to, again, it's unfortunate that it's my generation that received discipline from our parents that refuse to pass it on to our children because we think we are becoming modern and we used to call those discipline suffering. Yeah, our children are not suffering now, but Nigeria is suffering. because we are not taking to. So the money is there, just like I said. If only we use it well. Accountability is one of these things. Trust. The same thing my brother was saying. People will cook up figures. It starts from small things. JAMB, today they have arrested how many people for forging whatever. Parents are going to do an exam for their people. Those are the things we need to deal with. When we focus on that, on those simple accountability things, then we can use our money properly, and then we won't be begging everybody. At the Gavi meeting, which I was, when they told us, they gave us 800 million for 10 years. And I'm saying, if Nigeria spends this money well, we can fund Gavi.
Mm-hmm.
Yeah. And it takes a country to have that pride in itself. India was in the same category as us. The Indian people and the government decided that we are not going to have enough with this polio. They've not had polio for the last 5 years. I mean, the population of India is 1 billion or more than that. They were able to do it. We can do it if we change our attitude.
Yes. All right. Thank you so much, Prof. A round of applause. The work of NCDC will be very difficult if states and local governments don't do their own part of the work. And let's go back again to money. Last year, you launched the National Action Plan for Health Security. It's costed. So we know what it's going to cost to protect the health of Nigerians. How are we going to mobilize these funds, apart from the federal, but the states as well as local government areas? Well, for us at Nigeria Health Watch, the project we're running, Prevent Epidemics Niger, it's all about pushing for funding, because we realize that ultimately it's all about funds, money for us to do this. So, is NCDC appropriately budgeted for 2019, for example?
Well, we tried our best to try and present what we need. It's left for them to give us what we think we need.
Yeah.
Well, the other areas that we're doing in NCDC is trying to approach the private sector and get something. We have this A for EPR, and then that's A for Epidemic Preparedness and Response. Is a forum where we have private sectors coming together, and so we're working with them. We're also working with so many NGOs trying to sensitize them to be able to support us in most of the activities. Because, yes, it is a lot of burden on NCDC, because the states, well, some states are trying, but most of them are really not, it's not their priority. Health is not their priority, but their priority list. And so, most times when there's outbreak, the national is the one that provides the resources, the supplies for them to manage the outbreak. So we have, at the NCDC, we are using a lot of resources to support the states, and through our partners, of course, like Prof said, we've been going cup in hand, begging for support from our partners, and they've been performing so well.
All right. Thank you so much. Mai.
Yes, sir.
The work that MPACDA does, providing leadership, primary health care, is really responsibilities of local government. Let's be honest about this. How have you engaged with local government to take responsibility and also to fund, to provide money for this? We should not be depending on donors for immunization. Let me also repeat myself. How do you engage with local government councils to do this?
We have been complaining that we have inadequate health workers in Nigeria. Some people, when they say inadequate health workers or lack of health workers, they think doctors. Doctors are not only health workers in this country. Doctors are running out to look for, I'm a doctor. They are running out to look for greener pasture. But if you look at states, hardly you see a state in this country that doesn't have a school of nursing, a school of midwifery, college of health technology, and they graduate every day or every year. Where are they going? The local government don't employ them. Number one. Yeah. If you don't employ me in my local government because you depend on national hot cake every month, one hot cake from the national, you don't employ me. What do? I go and look for a butcher and now open my chemist and begin to sell all kinds of things. So local government don't employ because they say they don't have fund, number one. Graduates are being graduated almost every year from all these school of nursing, So this issue of inadequate health worker does not arise. Specifically, let's say inadequate doctors. Number two, political interference. When you go to urban PHC, you see millions of health workers working in a facility. But when you go to a rural area, it is just a poor man that doesn't have any relation. He doesn't know, he doesn't have godfather. He is the kind of people they will send to Sambisa Forest to go and work. But the other ones are wives of local government chairman, wives of the director of primary healthcare and co. So we keep on engaging these local councils, advocating for them, soliciting for support. Like my sister said here, they will tell you that, look, they have other things to do, not only health all the time. Agriculture is there, water is there, every other things are there. So the most important thing is that we should not lose courage. Let's keep on engaging them, talking to them, engage them through their governors. We have meetings with governors, national Nigeria governor forums all the time, telling them this, like the mix that we had the report. It was a good advocacy tool for us. We used the mix report to go to the state, tell them Sokoto 3%. Can you imagine? And administrative data of Sokoto was over 80%. Nix showed Sokoto 3%, and it crashed down the whole Northwest coverage. Lagos and others in the East, South, they were high. But Nigeria as a whole, 33. Who caused that? Northeast, Northwest, these two zones, and few North Central states. So the issue is that we have been engaging them, but you know, you can take a horse to the river, and you cannot, complete that one.
Okay.
So we are, of course, we are trying our best.
Yeah.
We are doing our best, and we will still keep on doing it until we see that we achieve the goal.
So Chika, again, money. I want us to focus on this money issue.
Money, yes.
From the work that you've done, and I'm happy, you know, that you adopted a community, tried out different strategies, and coverage improved. How can we improve domestic resource mobilization? We should not be dependent on donors to fund immunization. And how can we do that from your own experience?
Domestic resource. Wow. From my own point of view, the government should do their work. That's my own point of view. You have a job to provide vaccines to the citizens of Nigeria, and Nigeria has the money to give to you. Please provide the money. Because the money is there. The states have budgets and they're giving money. National, they have money. Please give us money so that these children will be saved, the adults will be saved. For me, it's a very simple thing. But there was one time we had NIFT, National Immunization Financing Task Team. After all the investigations, all the discussions that we had, what mattered the most was that Nigeria should please fund their immunization program. We have money. The states should support. The LGA should support. They all have money given to them. That is the critical thing. Start looking for money from any other place, as far as I'm concerned, is going too much out. Let everybody know their own responsibility. Their own responsibility is that you should fund your immunization program. It's as simple as that. Stop looking for somebody else to come and fund it for you. Because by the time you start to say you're looking for other people, PPP, this one, that one, people will leave their work and start to expect other people to fund it for them. The primary assignment, that funding of immunization, is domiciled with federal, state, LGA.
Okay. So my question goes to Mrs. Elsie Ilori. You spoke about messaging. Do we really think that we have gotten our messaging right? We know that we have several audiences. We have the grassroots, we have the youth, you mentioned Twitter. My concern is that sometimes our messages are not put out in ways that if they are deconstructed, the messaging is not lost. I'll give an example. I'm sure many of us here have seen an interview between Mo Ibrahim and Dangote, where he spoke about everything from of everything he has done. But a snippet that went around the internet was how he withdrew $10 million and took it home.
Yeah.
I bet that not 50% of those that saw those snippets never saw the full interview.
Yeah.
So how do we put out these messages so that the audiences would get the messages, even no matter how much they are deconstructed, the messaging is not lost in translation as it goes out?
No.
Yeah, the question I'm asking him in terms of deploying the resources that we have, particularly the midwives and the nurses. You had a program in your agency that was supposed to take in midwives and carry them on for 2 years at least and phase them into states and local governments. How is that program faring, and how do you revive that?
One of the reasons why I'm here is to find out from you experts whether immunization culture, how much of it has been introduced. We went to Kano, for example, on one occasion, the Society for Family Health, of which I was a president for quite a long time, only retired last year. We went to go and talk about immunization. And there was a story that the Americans have made that drug and put anti-fertility drug in it to give our children, to make them sterile, to limit the number of black people in the world. Now that was, as you know, totally untrue. And when we the place where we started, we wanted to demonstrate and talk to the public. When we came, it had been converted into a mosque. There were people with mats all praying here at the vehicle where we were going to demonstrate. So we had to quietly sneak away. How much has immunization been established as a cultural practice of Nigerians?
I would want to ask what NPAC is doing get state government, because we know a lot of LGAs can't really do that on their own without the state governors. So how is NPACDA engaging the states to solve that challenge, knowing that we won't be able to make huge impact without having adequate human resources? And for PHCs, not just those that are in the facility, you're supposed to have junior community health extension workers who have a lot to do at the community level. So this is almost non-existent because we don't even have enough for facilities. So it would be great to know what NPACDA is already doing or what they plan to do. Then secondly, on data quality, one interesting thing is we have outbreaks of vaccine-preventable diseases, and you look at the data of immunization coverage, and you're having more than 100% coverage. There's been a lot of debates at some point about the denominator and all those things. To what extent, given the emergency operation centers and other structures NPACDA have put in place in recent times, to what extent has it been able to address that? Because if our data is saying we are covering everyone and we are having outbreaks, it doesn't quite add up. So
Okay.
how do we solve that?
So the immunization culture that you're talking about is good for us to say we're starting a movement. We should start a movement in such a way that it becomes natural for somebody to just say, I want to go for immunization. And you know the good thing, it is possible. It is possible. So, and that's where I'm focusing on. Right now, what we're doing, there's a program we're doing now, like Adopt a Community. That program, I want to stand to explain this one. Thank you. That program, if it is followed diligently, will succeed. And what the program is, for all of us as citizens, it focuses mainly on immunization coverage and PHC, primary health care. What it does is that every individual, we call ourselves Nigerians, we keep complaining every day about the government this, no financing, no coverage, no this. So take coverage. Where you live, there's a PHC that is near you. Where you live, there's a small community that is near you. So if you want to take only a PHC, tell yourself once in a quarter, that is 4 times in a year, let me adopt a PHC and go there and see, is the water running? Tuesdays, are people coming for immunization? Do they have antigens? Don't they have antigens? Do they have lights? Do they have simple things like that that you can do? Everybody can do. Note that I said, take a PHC that is near you. So don't go and take a PHC. Don't say because I'm from Zamfara, I'm living in Abuja, I'll go and take a PHC that is in Zamfara. It won't work. Take the one that is near your house. And just 4 times. And when you go there, you notice that the nurses, they don't have, they're supposed to do polio, they don't have polio. Ask questions. How come you don't have this vaccine? By the time I ask, you ask, this person asks, that person asks, the next time, they will make sure that they have. Little by little, the culture starts. That's how the movement starts. So we have to get to a point where we stop complaining. Then the little we can do, we start doing. That is the culture. That is what I want us as Nigerians to start. That movement has to start. Everybody in my NGO, we are in 5 states, everybody must adopt, whether you like it or not, 4 times in a year. And if we're able to do that, you will be surprised about this coverage issue. So let us focus, let us know that it's the financing that is the issue, but at least the coverage, we are there. Thank you.
My brother was talking about the midwifery service scheme that was conceived in 2009, due to the fact that we had inadequate skilled birth attendants at the PSC level. So the agreement was that we recruited the retired midwives and we signed MOU with the states. At the federal level, we were paying them 30,000 naira. The state should give us will give us counterpart funding depending on the capacity of the state as salary to the midwife. 20, it could be 50 or 100, depending on the capacity of the state. And the LGA will provide accommodation for the midwife. And the money we were using at the federal level was the debt relief grants. Fortunately, I was in MDG's office that time. The money was the DRGs from the Paris Club. So sustainability became an issue. Some went to the state, some state couldn't pay, but federal government was paying, regularly. Some went to the LGA, they couldn't give them accommodation. But the MOU was signed. State pay counterpart funding, LGA will give out accommodation to the midwives. We couldn't sustain it because the MDGs were transiting into SDGs. And when this new government came, the government now diverted the fund directly to governors to pay salaries. So the midwives have to drop out. Then one of the agreement was that the state should absorb them at the end of, because it was agreed for 3, 4, 5 years. But the state, some states couldn't absorb them. But I can tell you, some states today have absorbed the midwives. Now, that brings me to the second question. Engagement of state on human resource for health. Because those midwives retired, some of them were returned, some of them were dropped out because payment was, was not regular. We now engage the state. I told you about the schools of health technology, nursing that always produce midwives, nurses, and others. So we now engage the state and engage the union to make sure that these nurses or midwives do 1-year internship. We deploy them. They come to to the agency. We train them. We deploy them to the state, to those facilities that don't have skilled birth attendants, to do 1-year internship. This was an agreement between the federal government and the Medical and Health Workers Association. You know them now, if you try anything they will mess you up. So we have to enter agreement with them because of this. So this is what we have done with the state. Any state that has this school of midwifery, health technology, nursing, that basic midwife, the basic before you now go into training, We bring you people, give you orientation, deploy you, and we give you stipends monthly. That is what is happening now. Then, on the issue of data, my brother, if you enter the National Primary Healthcare NEOC today, you will see the dashboard of all the 774 local governments on RI. If you are running out of vaccines, it will show red. One antigen. If there is stock out, it will show us red. If you are not immunizing the way you plan, your sessions, maybe you plan for 4 sessions in a month, and you did only 3 sessions, we plan, and you will send signal directly. So there is feedback. And again, we are built on supportive supervision. Strengthen our supportive supervision. So we have chiefs, the community health influencers and promoters at the community level where they are liaising with the data officers, make sure they filter the data, they know which ones are outdated, which ones are adulterated. And if you mistakenly adulterate, we sanction. I forgot to mention from the beginning, we sanction every health worker that mess up with immunization activities at the grassroots level now. So everybody is on his toes. It's no longer business as usual. Thank you very much.
You know, we generally give messages like do not or do, you know, but what we now see is that it's not working. We need to have targeted messages. So what we do is to try and understand the culture of the people. Try and understand the status of whom you want to get the message across to. Socioeconomic status, you need to know the culture of the community, and then get the content of your message reviewed. So it's not a general message that you send out to the public, but you have a targeted message. That's what we are trying to do. So now, recently we've just reviewed some of our messages, the contents. We've not sent it out, we just did that just last week. Went to Ondo State to make sure, you know, Ondo State is one of those states, the Lassa fever state, and we have tried as much as possible to understand why we keep having Lassa fever occurring in these some set communities. So we went there, did some assessment, we involved the communities, because if you are passing a message across to them, you have to involve them. They need to understand why what you want to pass across to them. And so the content of the message must be targeted, not a general message. And I also talk about the youth. Of course, the way you pass a message across to the youth is different from the way you pass it across to their parents. So it's a different ball game. You cannot have a straight jacket message to people. So that's what we're doing right now. So we're trying to review our messages to relate to the people that we're sending the messages across to. Well, that's what we're doing right now.
Okay, thank you so much, Prof.
Thank you very much, sir. I thank Professor Gill, because as I said, he reminded one of the things of the past. Like I keep saying, we can still get back to those things of the past. The culture of humanization is overridden by the culture of accountability, the culture of responsibility, and the culture of continuity. If we have all those things in place, culture of humanization will fall into every aspect of what we do. I think one of our colleagues mentioned the fact that Nigeria was at one time producing some of his own vaccines, right there in Yaba. I mean, that was what happened. And I remember the yellow fever of 1984. The diagnosis was done in the lab in Ibadan. And as soon as the result came out, the Yaba people released the vaccine. Today, if we have yellow fever vaccine, we had to go to Dakar to confirm. And then we had to beg the ICG to give us the vaccine. So you can see how far backwards we have moved. But I think if we did it before, we can still do it. And I think that's the message I think we need to keep pushing on. And one thing, when Chika was talking about adopting a community, you know what was going through my mind? Where I live in Ibadan, there's a village just behind me. I used to walk around there and I see the level of poverty. I'm encouraged. I'll come and learn from you. Maybe that's one of the villages in my old age that I will adopt. Perhaps they will end up calling the village Tomori Village when I finish. But that's talking seriously. I would talk about it with him. But one point I want to make before we close. The other day, UNICEF said that there were 10 million stunted Nigerians. I can't remember the number. You know what occurs to me? That some of these stunted children who grow up in future to be in the executive, in the legislative, in the judiciary, and then we're wondering, why is our country backwards? When you start with stunted children who grow up with stunted adults who are now ruling you, so that we need to take care of our stunted children so that our future will be better. Thank you very much.
Is it about time we start to think of how we bring the private healthcare system in tandem with the public healthcare system? Is it about time we start to use electronic system to collect data rather than saying we've immunized or we've vaccinated 20 people in Ondo State, 15 people in Ebonyi State? If we have a record that can be accessed from private to public healthcare system, that will bring all these systems together, wouldn't we be able to achieve what we aim to do by saying we want to immunize our people? Should we start? Is it about time to think of restructuring our healthcare system?
All right, thank you so much.
Similar, most of the issues that have been discussed, I'm already aware. Most of us are aware.
Yeah.
However, there's the point about multi-sectoral engagement. And so we're talking about them in silos and the kind of engagements that we've done. But I just wonder, and I'm looking especially at Mrs. Ilori, about how NCDC and even primary healthcare are working with other sectors outside health to ensure that immunization, the gap is already bridged. So that's one question. And then the other is a comment generally, just saying that engaging, and I like what you said, Chika, right? Yes, it's about, because a lot, and it was already highlighted and summarized even with the presentation, that when we talk about immunization, it's not necessarily about the vaccines. There's a lot of issues around it, but centered mostly around political will, right? So how do we work with communities? Engaging communities to own, citizens' engagement is one thing, providing messaging is another, but empowering them to be able to hold government accountable is another area. So it's just putting that out there that, yes, it is one thing for us to keep giving them messages. It almost appears like they don't know, and we are giving them, we have all the answers. But engaging them and them being able to understand their rights to health and being able to engage. So that's my general comment on that. But my main question, multi-sectoral engagement, and how do we go outside this nucleus of health and working with other stakeholders, whether it is in Ministry of Finance or other disciplines or social scientists, and ensuring that this happens. Thank you.
In terms of funding, I think a lot of things have been talked about funding. So I'm aware that the Basic Healthcare Provision Fund, which is supposed to change funding mechanism for primary healthcare and by extension for immunization. So for me, I think this is something that we should all get interested in, to track the money. This has been protected by law already. So I think there are a lot of civil societies here. So I'm using this opportunity to call on all of us to see how these monies are going to be spent to strengthen primary health care and immunization. Because this will also help to strengthen health insurance, which is another way to help universal health coverage. So whatever we are discussing, immunization cannot be discussed in silos. It must be discussed along with strengthening the health system overall. So we are already restructuring by this, if I could partly answer my friend's question there.
Okay.
Then my other concern has to do with urban health interventions. We are talking about immunization. A lot of the focus seems to be in the rural, hard-to-reach area. But we are beginning to have a lot of problems in the urban centers. Prof talked about the issue of Lagos having, even though they have high coverage, but the numbers are huge. And a lot of these numbers are in urban slums, urban uncompleted buildings, gateman houses, you can name it. The gateman has a child. The boss may have taken his own child to immunization, but the gateman may not have. So we need to develop strategies. I'm happy with the CHIPS, I'm happy with the NERIC, but I think we need to do a lot to focus on some of these neglected, invisible children and persons in the urban communities. Thank you.
How do we hold the government accountable? How do we stop cooking of figures by we, the health workers?
The problem with restructuring, without restructuring your mind, without restructuring your attitude, is going to be a sophisticated decadence that we're going to end up with. Talking about electronic figures, the person who wrote the thing down in the book, the guy who sends it by telling whatever, if he's not honest, you get the same thing. Only that you get your result, your negative result faster than when we used to use handbook. Therefore, behind all the things we're talking about, whether electronics, whether whatever, if the attitude is not there, is not changed, we are only going to make things worse for ourselves. When we talked about, people were talking about restructuring this country into the old regions. And the question I asked was that, are the leaders we have the same caliber as the leaders we had when we had those old regions? Will you compare any of our leaders now to the likes of the Sadaunas, the Awolowos, and the Azikiwes, in their attitude to the way they develop their country? If you restructure to these current dealers that we call leaders, into different places, they're going to deal out the whole state to yourself. And that's the problem. I think while we're talking about restructuring and all those things, when we're talking about adding more funding into health, has anybody asked, how do we spend the one we got? According to some of the studies done by that, only about 4 to 5% of whatever fund is allocated to health actually gets into health. The rest gets into people's pocket. And so that's why I think, in addition, why it is true that we need more funding. When they came to Abuja in 2001, I can't remember, and said 15% for health, which state country has achieved it or has been consistent with it? If we make mistake in some of those things, I think we should be courageous enough to go back and say, we made an error when we said 15% for health. We have done in stages, 10% this time, 2% later, and then reach that one, not say 15% at the time. Education will ask for 27, roads will ask for 38. By the time you add it up, you get the coverage that we usually have in Nigeria, 150% of the money. How are you going to do that? So I think it is important for us to, as we are talking, to look at those other basic attitude to life. And preaching to the convinced, sometimes you find amongst the convinced who are not really convinced. And so you catch some of them, like Chika has caught me now, to go and look at the community behind my back. So that's one thing. If it's that you're leading you achieve, this meeting has been successful.
Thank you so much, Prof.
Involving the other sector. Health is not only for the health sector. It involves all the other sectors. Like for us, we involve the Ministry of Agric, we involve the Ministry of Environment, Water Resources. All those are connected to health issues. So there is a multi-sectoral approach that we use. Now, I will also always go back to Lassa fever because, that's one of the areas that we have really worked on very well. And for Lassa fever, our approach is a One Health approach where we involve the Ministry of Agric and the environment. And we found out that, because initially when you call Agric, oh, please, we need you to be part of this, they say, oh, it's only Ministry of Health. We need money from health to do our work. But they have the mandate to do so many things. And so our approach with them now is, how do we get them to understand that it's not because of Lassa, but they could do this because of the economic gain? Because that's what Agric understands. Mm-hmm. To them, what is our own economic gain there? What do we need to do? We need to talk to the food processors. We need to talk to the hunters. So is it because of Lassa that we need to talk to them? No. You need to talk to them because they need to do 1, 2, 3. And for them to do it, these are the things that they need to put in place. And so Agric is doing their own part. They have a plan now. Ministry of Environment, we are so pleased with them now. They have now realized that, in fact, most of the diseases we talk about, if our environment is clean, I don't think we'll be having issues with even the immunization we are talking of. It's true, because the environment is nothing to write home about. But I think they are also doing their part because they have seen the importance of their own mandates, their work in terms of the health of the community. So we involve all the sectors. The water resources, of course, when there's no water, all know what will happen. We have cholera coming up now because this is the season, especially in the south. When there's no water, people go out looking for water. When there are rains, the water, the stream where they wash clothes and do all sorts, flows down to where other people are collecting water to drink. And so you have a lot of cholera cases. So the water resources is also aware of that. And so they are doing their part. So we work together with all the sectors, including the private sectors, of course, because most people visit the private facilities. And so you cannot do without working with the private sector. So that's, is a very important part of what NCDC is doing. We have the collaboration, including the military. Let me not miss out the military. Because, the military is a community on its own. If they have cases, it's difficult going into the barracks to get, information. So the military is also part of our work, our team, because we have the Emergency Operation Center and Incident Management Center, where we have all the partners coming in, working with us. When you come to NCDC, you will not even know who is who, because we're all working together. So you won't know who is a partner or who is a NCDC staff. So I think that is one thing that we need to do. We need to involve all sectors. Even with the immunization we're talking about, I mean, it's not all about health alone. It's not all about the health workers. It's about everybody. And I like what Chika said, that we all have to take responsibility. It's not, like the minister said, we're all surveillance officers in our community. So whatever is happening in our community, we should be vigilant. We should be able to monitor and get information. So I think that's one of why I like this gathering, because it's helping us to be able to think and, see what we really need to do. Mind you, we have here the elites. But the elites are also one of those that are guilty of not getting the message. Because we feel we know. And so we do not listen to some of these messages. We have posters all over. We have the radio messages. Once they start talking about keep your environment clean, the elite feels, oh, my environment is clean, so why should I listen? It's for the rural person. It's not for me. Somebody talked about the immunization when you're going for the campaigns. It's difficult getting to those houses with the high walls and immunizing their children. We're having measles in America. How did it get there? I do not think it's the villager that took it there. It's the elite that took it there.
Okay. All right.
So, what are we talking about? So I think we need to talk to ourselves. We are all seated here. We're talking about getting the immunization to the community. Who are the community members? The community members are all of us, because we all belong to a community. Even where we have these high walls and whatever, we're all part of the community. And so it should start with us. I'm happy we're doing this now. Thank you.
All right. Thank you so much. And Professor Tomori confidently showed me that if we were preaching to the convinced, then maybe born again should stop going to church, because they are also convinced. And they've been hearing it all these years. I think one thing that you touched on, Mrs. Ilori, is the social determinants of health. And this is something I say virtually in every gathering I go to. 46 million Nigerians stool in public. That's almost the population of South Africa. Stool in public. So how can we even begin to get some of these things right when we don't provide some of these social determinants of health in our discussions about improving health for Nigerians? So, Dr. Mai.
The multisectoral issue was directed to the two of us.
Okay.
So in addition to what my sister said, we have a national EOC domicile in NCDC, where all the partners, the relevant partners, come in every day, every week to meet and deliberate on issues that bounce down on things like outbreak of CSM, cholera, measles, Lassa fever, and co. So we have regular meetings Tuesdays of every week and Fridays of every week for Lassa fever, Tuesdays of every week for cholera. So we involve all these partners, especially water sanitation, Ministry of Water Resources. You know, when you are managing cases of cholera or any outbreak, we have 5 pillars where you do case management, surveillance, logistics, and vaccination. That is where NPACDA comes in now. We deploy RRT to where there is outbreak to go and do all these things, and they will all fall back on us for vaccines. We are the ones to send ICG requests to ICG for them to give us vaccines for any outbreak that we have in this country. So multi-sectoral collaboration is very important. That is, if you look at our topic, stronger together. It's the same multi-sectoral. And together we get it right, isn't it? Mm-hmm. Yes. A broom cannot carry, what do they say? So please, lastly, sir, Dr. Ifai, my data friend, I forgot to mention that we have implemented use of ODK in all our programs in National Primary Healthcare Development Agency. So gone are the days where you will just go and lie down in Sheraton Hotel and give us data in Katsina. You understand? So when you use ODK, there is GPRS, geocoordinate, everything. It will show you the location. If you didn't go there and you submit the report, we will see it at our national level. So at least we have tried, have we? Thank you.
Thank you. You've tried. We'll keep pushing. Mm-hmm. Okay, Chika.
There's a proverb in my place that says that if you read the things fall apart, it was there, about the men plant the yam, and then the women plant the cassava and small things around the yam. But for you to have a variety of food so that the food will be sweet, you have to eat yam with some of those things. So the government, they have their role to play. And their role to play, nobody else can do it. It's the government that can do it. And then we have ours that we also need to play as citizens of the country. So MPACDA, based on the emergency, they form different groups, NEMCHIC, CHIPS, different groups to make sure that at the end of the day, they're able to give us data and give us a strategy on how to solve our problem. Everything has been drilled down to community. If we get it right at the community level, it goes up and we will get it right. Because we just started the African Vaccination Week, and it says that together we win, and that's the truth. So I say that all hands must be on deck. Even in the FCT, we're a member of a task team that involves the chiefs, the CSOs, the FERIC, all sectors, multi-sectoral. They're all coming together to say, you know what? We're going to shoot this thing down and make it work. And all in the FCT, as I'm a member of that. And I believe that if we all come together as a team, not complaining, let everybody do their part, we will succeed, and you will be amazed at the extent of the success. That's my bit. Thank you.
All right.
We have not brought a strategy whereby we will engage these husbands in the northern communities. Because one, we assume they are learned, we assume they know, but honestly, they do not know the importance of immunization to their children. So let's refocus. Let's look at these husbands. Let's strategize. Let's have maybe focus group discussions with husbands. Let's have town hall meetings with husbands. Because the women are always rich at the facilities. We, the health workers, we give them health talks at the facilities when they go for immunization. But we hardly get the men to interact with. So please, at this forum, I would like to seek the efforts of Nigeria's Health Watch, MPHCDA, CDC, and other partners that are here to strategize a way of reaching these husbands, either in their farms. If they are herdsmen, let's move if they are nomads, let's move to where they go and rear their cows. Let's find a way of reaching them, give them the right information so that whenever, because sometimes when the health workers go even to the house for immunization, they are being chased away.
I may have to cut in at this point.
Okay.
So how do we engage men
Yes.
in northern Nigeria
Yes.
for immunization.
Yes.
Okay? Thank you so much for that. And thank you for coming all the way from Bauchi for this event. I think probably we'll just take ladies at this point. I'm biased for that. I have 2 kids. They are all daughters. So that's fine.
Thank you. Good morning, everybody. My name is Dr. Udo Dirim. I worked as a data officer for the M vaccination project. The M vaccination project was the introduction of a mobile technology to address issues of immunization. It was piloted in Kaduna State, 2 LJs in Kaduna State.
Yeah.
It's a transactional tool that addresses some of the issues that have been discussed here. Immunization coverage, community engagement, defaulter tracking, and all whatnot. We had worked with the state's primary healthcare development agency in Kaduna State to pilot this tool, and the success was recorded. You know, we had a dissemination workshop here in FCT, and I know that the National Primary Healthcare Development Agency was invited. I don't know if you're aware of the tool, the potentials of the tool, how it's able to address and solve some of the issues that have been discussed here. And if there is plan for uptake or adoption of this tool to use to solve the issues of immunization, and to use it alongside some of the strategies that the lady made mention, adopting a community. I don't know if you are aware of the potentials of the mobile technology.
What's the name of the tool again?
M vaccination.
Vaccination.
M vaccination. Yes, M vaccination.
M vaccination. Okay. Thank you so much for your question. 2 more ladies, then we end. Ladies, you're not taking this. Okay, there's one there. Okay. The ladies have come out. Okay.
Member of Form 1, just advised by basically. Immunization is one of my lines where I supervised for many years. At the last but one speaker talked about the men. There's this incidence of non-compliant states during the polio vaccine where we didn't comply. I was sent to Sokoto for supervision. So I want to agree with her that men are our problem. The men.
Men are our problem. Let me just echo that.
There's this local government in Sokoto. We were in the house for 3 times. We went there. The women refused that except the men allowed their children to be vaccinated. So please, I go in line with the last speaker, but one. So please line up, get up a strategy where we can encourage our men to please allow our children to be vaccinated.
One thing that we've seen is that people respond better to personal stories. They respond better when they see examples that they can refer to. So if we could also consider using personal stories, and as my sisters have mentioned, the issues with husbands, with taking up vaccination for their children, if we could incorporate the use of families, women, men who have vaccinated their children, some of the challenges that they face that are peculiar to certain communities, I'm sure we will see positive change in many of these communities that have very low coverage. Because as Nigerians, when Dr. Nsofo talked about being aspirational with regards to health, people want to see something that they can do to prevent a negative thing that they've seen in another person. So once they have a visible example that they can refer to and juxtapose that with their own family situations, I'm sure we will see a lot of benefits and a lot of change in our communities. Thank you.
Like what Adeze said, human angle stories. People respond to stories. When people visualize, people respond to stories, people respond to money. Like the Dangote issue that was mentioned. I can't even remember any other thing he said apart from the 10 million. It was just the 10 million. I started wishing how I could, touch $10 million. So every other thing. So if we want health to trend, if we want immunization to trend, and when I say trend, I'm not looking at it as trending for people who are on the social media alone. If you want it to trend in communities, you want it to trend everywhere you go, in the urban areas, in the rural areas, as something that everybody wants to aspire, like you said, aspire to have, Let it be the in thing to say, yes, I have vaccinated my children. And it becomes a status thing to say, yes, I have vaccinated my children. Have you vaccinated your children? You know, and I want to be that mother that will say, look at my baby's card. I have done it. You know, we have to start to think of those kind of innovative strategies. And it doesn't necessarily have to be health-based. Let us go to other aspects of life. Even if it's any other thing, aviation, whatever it is that works in any other place, bring it to health and make health not to be as boring as it is. Because if there's one thing that is boring, it's health. The doctors feel that everybody knows the mokoka, many, this, that, you know, and they don't understand that after 2 minutes, you have lost us. So the essence of your conversation or whatever it is you're trying to pass is totally lost. So the second thing I would say is, apart from the trending, simplify your message. Simplify, must it be capacity building? Must you say capacity building? Must you use the word capacity building? Training. We want to train people. Simplify things. You know, understanding is very key to passion. You understand? Understanding is very key to passion. The fact that even a man that wants to toast a woman, the woman must understand the toasting lyrics now. You cannot come there and start to say, oh, my this, that. Say it the way it is that somebody can relate with. So those are the issues I think we are having as a group. Especially people in the medical sector. There's a problem. In the English is already bad enough that it's difficult to understand.
Yeah.
Then you now focus on citizens' engagement. We want farmers, teachers, this one to be involved. Simple. And I'm telling you, half of our problems will be solved by simplifying our messaging so that to get the passion of people. And then once we get the passion, simplified engagement, then you are able to involve people. Let people adopt community. Don't judge them. Whatever it is somebody wants to do, even if you just want to go to the health center once in a year instead of 3 times, it's fine. So my own there, please, I am begging all of us who are doctors and the technical people, step it down, Step it down so that we, who are the community people, can also step it down. Half of the time when they're giving presentations, I have to go and look at my internet to find out the meaning of many of these things. And the people in the community who are the ones who you want to do those things, where do you think you place them? Me, I have masters, I'm finding it difficult. Then what do you want the people in the community who are the ones who will actually immunize their children, who will actually adopt, who will actually do those things? So I'm saying 2 things here. Simplify your messaging. Let health trend. Let it be something that is gold. Make it. And then my brother, you know that Nigeria Health Watch, they trend now. Your Efizi no get part 2.
But we'll break it down now.
You're breaking it down now. Okay. So you have to use your breaking down process to make it trend. Absolutely. So that we can now trend locally.
I totally agree with you.
You see, apart from simplifying, I think we have to train these people at the local level in their own local languages.
Oh, yes.
Because like when we go out there to train them, maybe either MNCH or immunization or anything, it is, they are the state people that train them at that level. At the national level, we can speak English. When you get to this, there are some states that when you get there, you even speak their local language for them to understand. Because not all of us are educated. Not all of us understands this English. You understand? So it is good to train them down there in their own local languages. Yes, my sister mentioned something on distance from household to the facility. We know the normal, anything more than 5 kilometers is very far actually. But what we try to do is that the chiefs that we engaged, those chiefs are being recruited in that location. You don't go and bring chief from Kano to come and work in Abuja, no. Or from different ward, no. It is the traditional ruler that selects all these chiefs based on some criteria. And the community must know them. And their major role is to mobilize these mothers and children, pregnant women especially, to come to the facilities. They have access to these houses. They have access to the men. They talk to their men, they talk to their wives. Actually, is something that happens in the north. Even if a child is at the point of death, if you don't ask your husband a permission, can you imagine? It's a big issue. It's a big issue. But we'll still try our best. We at the national level, we have been engaging traditional leaders, Emir of Kano, Emir of Sokoto, Emir of Ibi in the northeast, Taraba. You know, we usually have meetings with them quarterly. So these are the kind of messages that we pass to them. My sister, about the MVAC technology, I think among the pictures that you first saw, you didn't see my picture there. It's the ED that you saw, Abby. And the ED has different departments, different divisions, different units. My own is disease control and immunization. If I tell you that I know of this, I am speaking, I am lying. But I will promise you, I will go back to the office. Before I leave here, I'll get your email. Go and engage the appropriate people. Have you heard of this? Were you in the training? What are your plans? Are we ready to key into this so that it can, help us in our data management?
I really want to go back to our sister that talked about engaging the men. Yes, and that's why we're talking about having our targeted messages. Now, if we understood, if we were able to understand the reason why they are not going for immunization, we would have been able to target the men, sit with them, and talk to them. So I think that's one of the things that primary health care, I think that's one of the things you need to do, to try and find out why these states that have very low coverage, why are they having low coverage? We've said it here. I don't think any parents will not want their children to be healthy. And part of being healthy is immunizing your children. So I think that's one of it. Let's try and understand their culture, because the culture differs. Even the religious belief differs. So we need to understand what are their beliefs, try and work towards trying to convince them on their beliefs. And then we also need to understand their socioeconomic status. I said, like the elites now, the way you will get the message across to them will be different. So, okay, my brother, you talked about engaging the emir. If I'm living in Abuja here now, and you go to the emir of whatever that is in control of Abuja, he cannot tell me what to do, because we are all in their own secluded area. So if you say, emir, talk, and you say, okay, people around that are living around me do this, I'll tell you, you don't have a right over me. So you cannot tell me what to do. So we need to, target our messages. We know that for some communities, if it's the emir that will talk to them, yes, it will be effective. But for some, there's another way. So I think we need to also do that. And then while we're passing messages, we need to do a lot of evaluation. We pass out messages. How was the impact of the message? Have we really gone out to find out? Has it impacted on the people? Have they even taken it in? Yes, you tell me what to do, and I say, okay, yes, I've heard, and I don't do it. So how do you know that I do not do it? There must be a way for us to evaluate. So for me, my final message here is that I'm really happy to be here, and I want us all to be ambassadors of immunization, not vaccination, but immunization. Thank you.
I'm a very proud Nigerian. I'm proud that my country made me what I believe that this country can make you better, faster, and stronger than I've ever been.
Yes.
And so, make it possible. It is your country. Let us go together, and we can help back. But you will be better than we are, better than our generation. It is in your hand. Yes. Please go ahead and make it possible. Thank you.